Good afternoon, everybody. Thank you for joining us today for Healthmonix's first ever Fireside Chat. My name is Michael Lewis, and I will be your host for this panel presentation. On today's panel will be none other than Healthmonix CEO, founder, and health IT visionary Lauren Patrick, whose brilliant idea for these presentations started from. We are joined today by two of our favorite people and partners, Robin Roberts, co-founder of Chirpy Bird Inc. She is a policy and health IT strategist focused on practice success, as well as her partner, Joy Rios, the other part of the co-founder of Chirpy Bird Inc. She's a 5-time quality program author and a health IT subject matter expert. First, if everyone can answer a poll question that I'm going to load up, we'll get started with everything right away. All right, while that poll is there, I would like to get us started. So, we will be covering a number of topics during this presentation, and we hope to have some time to answer your questions at the end. If not, we will certainly reach out to you after the webinar. So please ask your questions to our panelists by typing in the screen on the right-hand side of your GoToWebinar invite application. These are unprecedented times in our industry as the providers, are being thrown through an obstacle course of changes to your daily routine. With shutdowns, remote visits, and an overall shift to pandemic mode, you have needed to adjust on the fly. There has been some relief out there with government financial relief programs and continuous updates from CMS, including changes to the 2019 MIPS program. Today, we are going to discuss, among other topics, changes to 2020 MIPS program and how it has increased in difficulty. CMS removed a number of the popular measures that everybody is used to reporting on. They even topped out more of those measures, making them hard to score well on, and has increased many of your thresholds, including 45 points to avoid the penalty, 70% completion on quality, and 50% of your providers need to participate in group improvement activities. Many providers also got a pass for the cost category in 2019. That won't be the case in 2020. And there are 10 new measures with many more coming as future years of this program start. So, you didn't sign up to listen to me speak. So before we get to our panelists, I'm going to ask a couple more questions for you on the surveys, and then we are going to get started with our questions. So the first question is, how did you finish up 2019 MIPS reporting? All right, thank you very much for that. And we're going to add one more here. Where are you currently with your 2020 reporting? Great. Thank you very much. So let me get my panelists up here for you to see. I apologize. There we go. Oh no. Oh no. Hold on one second. It's new to me. I apologize. Sharing. There we go. All right. So, perfect. All right. So our first question is going to be 2019 wrap up. We saw some last minute 2019 attestation changes, and we also are considering budget neutrality. How will this impact 2021 reimbursement? I'm going to
So,
go.
Mike, I think I'll take that one.
You
I'm
got
just
it.
going to jump in. So we know that when the changes came out, they came out and then they came out again and then they changed it. So they issued the same thing around 4 or 5 times as they clarified. But what we saw was a couple things. Some people did decide to bow out if they had lower scores or the possibility of a lower score. They did not submit. However, on the other hand, we had quite a few providers that really appreciated the extra time. And our staff, our customer support staff, was super busy during the month of April as people worked to improve their scores, to get more data in, to optimize the measures that they were reporting. And we were submitting data until literally the last moment, the last day of April. So we had a lot of people that really took advantage of that extra time to get their reporting done. Having said that, the worry is that because there was basically no downside for folks, because you didn't have to report. If you don't report, you would receive no penalty for 2021. We are fearful about the incentives for 2021 in that it's a budget neutral program. So if nobody is getting penalized, what is the incentive going to be for 2021? We do know that there's that bucket of $500 million for extraordinary performance. So if you're over a performance score of, I think, 75 for 2019, you will see part of that. But on the other hand, those that score between 30 and 75, we're not sure what's going to happen. CMS has made noises about the fact that they are doing some rulemaking or some policy changes, and my wonder is whether they might, fingers crossed, allocate some extra money for others. At that, I'll stop because it's supposed to be a chat, not me ranting.
Well, I'll chime in, Lauren, because I think that that's a really important point, especially since, considering for people that don't understand the budget neutrality of the program, CMS takes all the money that was basically withheld, in the form of penalties, and then redistributes that in the form of incentives. And if they're not going to be withholding any of those funds, there's nothing to redistribute. And it's hard to really make the case. Like, I honestly would be curious if people, they had anticipated that the incentives associated with 2019 could get close to 5%. So people that had really put in a lot of work were hoping to get, if I got a score of 100, you could potentially get up to like 4.69% of it, in their incentive funds. And now that is essentially gone, at least according to the budget neutrality of the program. So for people that had been putting in all this work, hopes to see a reward on the other side, I feel like that's an interesting thing to talk about, because, have you heard from clients? What did they say? It's kind of a wait and see mode, but I do feel like that's a big risk of the program.
I think there will be a lot of disillusioned folks if CMS doesn't take any additional action. Those folks that worked really hard, like I said, we had a lot of reporting still happening in April. They'll be disappointed, disillusioned, and I know we already were seeing that from the prior years because the threshold was so low. So it will be interesting to see what happens.
And I guess to that point, it's like if you're going to make the effort, you would want to make the effort to be the exceptional performer. So, you know, don't go halfway. If you're looking for any kind of reimbursement, go all the way and do the absolute best that you can so that you get into that, you know, excellent performance pool.
Thank you very much. That was wonderful. Moving on and sticking with more or less the same category, but cost was not counted last year. What do people need to understand about this and how it's going to impact them? Because as we know, they want cost to be just as important as quality moving forward. So back to you, Lauren, to start this one off as well.
Well, costs won't be counted for those that report as individuals. My understanding is if you're reporting as a group, it still will be considered. Joy, I don't know if you want to comment on that.
Sure, I'll comment on that because I had a similar understanding when CMS had notified and sent out, hey, cost is not going to be included for 2019. I thought too that they had meant for everybody, but it was in the details that they were really only talking about people who reported as individuals. And that's not most people. Like a lot of people report as groups. So groups are only 2 eligible clinicians or more reporting together under the same tax ID number. So cost still for a lot of folks is going to count.
Thank you very, very much. Adding to the next question, I'm going to go to Robin. Let's see if we can hear from Robin for a little bit. CMS lacks of changes for 2020. What do you make of fact that CMS has issued no guidance for 2020 reporting?
Well, when it comes to other programs and initiatives, CMS has issued some guidance. And so I'll look into my crystal ball and talk about where we have a precedence for what could happen. And so I think you're going to see 3 things happen. First, for those people that have information based on the current criterion, you can go ahead and throw it all at the wall, still get a score of up to 100, max out your incentive, and gain access to that exceptional performance bonus pool if your score is high enough. That's option 1. I think there's going to be latitude on the next 2 options. Number 2, they change around the reporting period. Maybe they parse or lessen the amount of time required for quality instead of a full year. Maybe they make it 90 days, or they back off the data completion threshold where we need as much data. And so I think you'll see an option for some flexibility, but with that, they may put a ceiling on the incentive dollars for those folks that choose to report less, still with the option to get a handsome score and keep that reputational piece intact. But the third option that I think we need to not forget about is where we've seen precedents for extreme and uncontrollable circumstance under the letter of the legislation and the policy. And that is, we have seen in years past when an area is impacted geographically by things like hurricanes that have either devastated an area or even had a mild to moderate impact geographically, you get a chance to kind of sit the year out and CMS will hold you harmless. You're not going to make any dollars, but you're not going to be penalized either. And so I think we're going to see options for all 3 of those come out. That's what I believe is going to happen. And so I'll let my colleagues weigh in, but I want to remind you, if you're thinking about just saying, I'm done, I'll just give up, that by the time your waiting rooms are packed again, or you're running dual workflow of telehealth and in-person visits, the clock is going to reset on January 1st. And Laura knows this better than anyone. And so you'll be trying to wrap things up or, get on board with the new program. So tapping the brakes isn't always the best idea.
That's a really good point, Robin. If you've got the time now to think about it, and we understand that a lot of people don't, but if you're in the circumstance where you can be thinking about it, and I think, Mike, you're going to talk about this a little bit later, you've got some new processes that you're implementing in your offices. It is a really good time to just consider how you might want to re-up your quality reporting and ensure that you've got all of your systems in place for the EHR, the promoting interoperability piece. So I don't think it's fair for people to just pass, because as Robin says, if CMS does not give people any options for the extreme and uncontrollable circumstances. You could be in a world of hurt. We know that thresholds, as you've said, Mike, have gone up. The program is theoretically harder this year, and you know, we have a lot of people that are just really marching ahead, especially those that, you know, feel like they do want to ensure that their quality component is where they need it to be. They're working on gaps in care. They're integrating telehealth. There's a lot going on right now.
You know, Lauren, I think people are out there and they're probably thinking, well, this is MIPS, this is what you guys do. But, you know, this is just one payer in their version of a program. We always tell people unabashedly, I don't care about 1 year's worth of penalties and incentives. It's really about demonstrating great quality at low to moderated cost to demonstrate really what will become a successful narrative of value-based care to be successful in the long term.
Guessing that means it's my time again. All right. Hi, everybody. So a couple things I wanted to bring by you. Make sure that you are asking questions, because it looks like we may have some time at the end for some questions from the audience, which will be great. I want to introduce one more poll while we are here. Here we go. If everybody can take 1 minute to take a look at this question. How are you integrating with telehealth? So early results are showing that it has had a very high impact on everybody's practices and organizations. It looks like there's 30 to 35% in both the 25% or more and 50% or more of the business. So that is very interesting, and thank you very much for sharing that information. The next question I'm going to go on to is about the guidance given by CMS. They discussed here more telehealth measures. They discussed here COVID-19 and an improvement activity. What other guidance and what do you think came from what CMS has shared with us?
I'll take that. So I think what's going on and what CMS is kind of hinting at is that they are finding ways to incorporate this pandemic into the program, because how can we provide, you know, a value-based care? This is really the time to shine in a way. So they've hinted at that by introducing this new improvement activity. So if you are curious about that and the details, it's around the subcategory of emergency response and preparedness, and it's all related to COVID-19 clinical trials. And so just to read you the description, it's in order to receive credit for this activity, a MIPS eligible clinician must participate in a COVID-19 clinical trial that utilizes a drug or biological product to treat a patient with a COVID-19 infection, and then report their findings through a clinical data repository or clinical data registry for the duration of their study. And so if you have not had a chance to go see through the NIH or other databases which clinical trials are out there, you would kind of want to work backwards and go find a clinical trial, see how you can participate, and if what your activities are aligned with that trial. This is a high weighted activity, so depending on the size of your practice, if you were a small practice and participated in this activity, it would be the entirety of the improvement activity category score. If you were a larger practice, so more than 15 eligible clinicians, then it would be basically half of your score. And Lauren and Healthmonix had actually put together a telehealth measure, you know, that specified through the quality, like through the quality category, which measures could count towards telehealth. And she really did a great job of detailing, you know, what within the menu options of quality measures are available to you. And really, you know, there's no one size fits all with the practice. So really identifying different strategies you could take depending on what your situation is. You know, if you happen to be seeing more telehealth patients, or if you're closed for the time being, you know, how you might want to navigate your strategy. And I'll stop there to see if any of my colleagues want to comment.
Sure. You know what? Let me hop in real quick because we had a question on a previous webinar about the 50% participation rate, and I thought I'll throw that in here while we're talking about it. The person asked on a previous webinar that they're a very large group and that the 50% participation rate will be extremely hard for them to get to, especially for a measure like the COVID-19. So adding on to that, where do you guys think that they should be prioritizing and moving forward with their improvement activities?
You know, Mike, to hit on the question, I guess the other thing I would think about is, you know, more than 50% of the eligible clinicians that report there have to do it. You know, if you're not going to be able to meet patient populations or patient cohorts into, say, like the new trials measure, we have expanded practice access number 3, that is the utilization of telehealth to expand practice access. I mean, for most offices in America, that's probably on autopilot right now. Check that out. That's probably a no-brainer for most people. So, you know, there's no shortage of options for things that you still have enabled, are probably even still doing with volume down and the digital delivery of care that's out there and available. And that's why we exist, is to help provide that guidance. So, you know, EPA 3 is another strong option that would be an easy button solution right now.
That's a medium weight activity. Is that correct, Robin?
It sure is. So for a smaller group or the larger groups, they're going to need to pick up one or more still. But it's something that requires really very little level of effort because you've definitely probably lived it for at least 90 days.
So the COVID, Mike, to your point, I think that improvement activity, if you are really participating in some sort of clinical trial for 90 days, then that's a great one. If you're not, I don't think you need to force it. And the 50%, just to remind everybody, the 50% doesn't have to all happen concurrently either. So depending on how the groups are set up, if you have like a group and it's in 3 different locales, one group could participate for one period of time and the second one for some other overlapping or not period of time, as long as each one is 90 days. And then the third group, if it's not needed to meet your 50%, wouldn't need to participate at all. So, you know, there's some analysis that needs to be done to make sure that you're going to cover that 50%. I do know that CMS has stressed to us as a registry that they are very intent on auditing improvement activities going forward. So we do want to make sure that we're being honest about what we're participating in, because in the past, I think they felt like people were viewing them more as checkbox measures. So you want to find something, I think, as Robin said, that really fits into your practice, that you're really doing and involved in. And I think the telehealth one is a great one for this year. As Mike was saying, that it sounds like 2/3 of you are already working on that.
Great. Thank you very much, Lauren. Appreciate that. And as we're moving in and talking more about telehealth, a number of questions have come in, as well as a topic we planned on discussing, but the impact of telehealth. And, you know, it is widely used now. There has been a lot of questions. We did a webinar on does MIPS data even matter right now? How does telehealth affect your reporting? And what is it going to do for your scores for all of the categories, including costs? And will CMS still allow telehealth? Where are we going from here? So Robin, we would love to hear your take on that.
Well, I'll just kick it off and say that, you know, most of those MIPS measures are looking at encounters going on, and those telehealth encounters, in most cases, and a lot of them, are still putting numbers into the denominator metrics. They are still making us eligible for things we say yes or no to. You know, Healthmonix did a whole thing about this in quality, that there are still qualifying measures that you should be getting MIPS data for to be driving performance. You heard Joy call out improvement activities. You know, there's still definitely ones we can be living during the era of COVID. And even though we've never lived through this phenomena, there's it's still very much at play. If you are seeing patients in any capacity, whether it's those new telephone only codes or it's a E&M encounter being delivered via telehealth, there is still ample opportunity and the data still matters. So if you're collecting quality measure data, don't hang up the phone without asking those questions.
So I hurt my wrist a few weeks ago and I did not want to go into the doctor. So I called up and I scheduled a telehealth visit, and she just started kicking off all of those quality measures, let's talk about your pneumococcal vaccine, let's talk about your mammogram, let's talk about your colonoscopy. And she just ticked right through the list, even though I was like, I just want to talk about my wrist. So I think it's important for doctors to consider that this is like a real visit. And if you're dealing with a patient like me that doesn't always go in for an annual checkup, that's a good way to snag them and get some of those quality measures ticked off.
And I'll add to that. We've been promoting, if folks need a refresher on all the things that should be included within a telehealth visit, Thomas Jefferson University has a course for CME credit that people can take, and it basically goes through, which it might seem somewhat basic and all the things that like, oh, you have it covered, but it just covers all of the bases to be really, really complete in, all of the information. And we've worked with folks who have updated their intake forms to be specific to the quality measures that they are capturing data for, and making sure that as, like to your point, Lauren, that a patient is being, on the intake side of things, that all those questions are addressed. So you can still have an opportunity to capture that data, even through telehealth visits.
Fantastic. Thank you very much. Telehealth hits all of us at home. All of us have had many of us have had appointments, checkups, specialty checkups, and so forth. And every provider that I've met with has done something a little different. So I think guidance from CMS, from people like the three of you, are really going to help move telehealth forward, because I myself don't think that it's going anywhere, and it will be here for a long, long period of time. So moving on past telehealth and past MIPS.
Hey, Mike, can I jump in here for a moment?
Oh, absolutely.
So I just wanted to say, so one of the things though is to really think about a strategy. And I know we're all crazy we've gone from probably this very stepwise implementation of telehealth to whoosh, it's in. But I went back and I did a study of some of the data in our registry and compared performance for telehealth visits to performance for in-person visits. And the level of the quality measures was lower over the last, say, 3 years, I think, for MIPS. So I just want to caution people that it is easy to let that level of quality slide when you're doing telehealth visits. And I do think it's super important to think about how you are going to integrate that, and knowing that in the past we've seen this difference in performance of 10 to 20% for telehealth visits. I just wanted to interject that. Sorry.
No problem at all. Appreciate it. Any guidance is really going to help our listeners today. So moving on, so MSSP, do you think there will be many providers leaving ACOs and needing to report on MIPS this year? We've seen the change already, but do you think it'll even be more drastic moving forward? I'm going to throw this out to you, Lauren, to start off the conversation.
So 6 weeks ago, I would have said yes, they're going to bail, because I think that CMS had not issued any guidance. But since then, I think at the end of, I get my months confused now, April, they did issue some guidance saying that they were going to call from January 1st through the end of whenever they declare the end of the pandemic, the health emergency is not going to count for MSSP. So I think organizations are feeling a little better, like they can stay in, and like CMS is trying to accommodate. The ACOs are supposed to be a step towards more integrated value-based care. So I think CMS is doing what they can to allow people to stay in those programs without feeling like they're going to be financially penalized.
Robin or Joy, you want to pop in? Anything to add?
No, I think that what we saw with that just speaks to the latitude that's being given during the public health emergency that is COVID-19. And so that was really helping kind of color, again, our response about where we think the puck is headed for the 2020 guidance that is still yet to come out around the MIPS program. So, but I agree. I think having a strategy, sticking with it, and what she said about the ACOs and those participants is absolutely true.
All right, great. Thank you so much. So I wanted to get on to our last poll question before we answer our last couple questions and move to some more of the questions from our audience. But here we go. Where are you with your practice? What's going on with you individually? Well, so far it's great. It looks like most everybody is open and practicing, at least at limited services. And that's wonderful news here. So let me close the poll in a second and jump right back in to our presentation. So thank you. MIPS in 2020, what are the realities? As patient volume is lower because of pandemic, what should you do as a team? And if you're preparing to reopen, looks like everybody here is already open, but I'm guessing as everybody is preparing maybe to ramp up their patient base, what should your practice know or be doing?
I'll take that. I think that we've had a lot of clients that definitely have a reduced schedule and have been really worrying about what can they do to keep their employees busy if they don't have as much work on hand for the staff. So we've talked to folks about training. If there's any sort of EHR training that you've been putting on the back burner, now would be a good time to get people up to speed. You know, one thing specifically with the promoting interoperability category that practices struggle with is getting the health information exchange objective up and running and working. Now would be a great time to make sure that all of your networks, like your referral networks, are talking to each other and can exchange information. You know, a lot of times vendors update the way that they do that on an annual basis. So make sure that you are aware if they've had any updates, that you know what those are. Improvement activities, like we had discussed earlier, now is the time like that you can be either identifying the activities you're going to participate in or using the time to implement. Ultimately, how can you set yourself up for success in the long term? And so we've had folks start working with their billing or, with their billing staff and making sure that they understand patient relationship codes, because that's something that CMS has hinted at being, something that's going to be more and more important as time progresses. Some of the more complicated areas of MIPS, the cost category is something that confuses people a lot. Now would be a really good time to start understanding the cost information of the patients that are attributed to your practice. So things that, anything at this moment in time that maybe in the past you felt like overwhelmed or didn't have time for, or something that was sort of not as important, it's an opportunity for you to take the time and set yourself up for success in the future. So and now is also a time you could be doing your security risk assessment. You can be checking in on your technology and making sure that all of the safeguards are in place for that as well. So if either of you want to chime in, go for it.
So I think the security risk assessment is really important right now. I mean, with all the telehealth we're doing, with all of the telecommuting everyone's doing, I have heard more and more stories about hackers thinking now is the time to get into this data. So absolutely, positively, that is, regardless of whether you're doing MIPS or not, that security risk assessment is essential for people.
Yeah, and if you're listening going, what the heck is a security risk assessment? It is the scoreless prerequisite to a quarter of your overall score in the promoting interoperability category. It's not an optional thing. It's one of those things that historically we see a lot of people check box, and the auditor loves to check on this thing. It's still the #1 reason people fail an audit.
And Joy, I was going to go back for a minute to patient relationship codes. I'm not sure that everybody knows what that is. Can you give us like a 30-second overview?
Oh, sure. So on the cost category, basically you are assigned the total cost of the patient, of patients that have been attributed to your practice. And it's depending on where that patient saw the most primary care services. And as Lauren had kind of hinted to earlier, not all of us or not all patients go to their primary care doctor every single year on a regular basis. So sometimes they may see a specialist. So in a wild example, sometimes all of the costs of a patient may be assigned to a dermatologist. And so when they are trying to understand those costs and break them up into pieces, patient relationship codes are a way for CMS to start dividing up and attributing the costs in a way that is reflective of your relationship with the patient. So are you seeing a patient for an acute visit, or are you seeing them episodically? Is it chronic, etc.? There's not very many codes in total. I think there's 5. But basically by assigning, your relationship to the patient, it allows CMS to break down the type of cost. And when they do attribute the cost to you and your practice, that it would just be for the cost that you are incurring, not all of it. And so it is kind of a long-term vision. Not everybody is on board, but yet, because there's a lot of training involved in making sure that everyone's kind of rowing the boat in the same direction, as I like to say. But now would be a great time to get familiar with those codes, or have your biller become familiar with those codes, so that you can start dividing them up as they are appropriate.
Thank you.
Anything you'd want to add?
No, I think that those are sort of, I think they're coming into their own. I think that they've been around for 2 years now, and they have not been widely adopted, but I think that eventually they will be. So it's interesting. It's almost a way to kind of claim a patient as a primary care patient, or, as you said, indicate what sort of relationship you do have with them.
Yeah, I always think, it's always voluntary, and PQRS started out as voluntary too. And when it's voluntary participation, we don't see as many people participate. But over time, I think that this is one thing that we can start to see, that it will eventually be mandatory. So you might as well get familiar with it now. This is my take.
Great, thank you. This is great conversation. I just want to put out there, I think I've been learning about MIPS and HCC scoring and different scoring from the 3 of you for half my adult life. So it's great to have all of you talking about some of this together. It's small worlds colliding. It's wonderful. So a final open question to the 3 of you, and so we could get everybody on with their day. But what are we going to do about moving forward? How are we going to get past this? What's our next step? Where is MIPS going? What's on CMS mind? You talked a lot about it, but if you don't mind wrapping up a little bit and put it all kind of together, I see everybody's brain churning. So let's see what you guys got. All right.
I got to say that we know that value-based care saves money. These programs, these initiatives, every payer out there has some flavor or some variety of these types of programs. So, if half of it having a strategy, as my colleagues like to say, is knowing what not to do, the thing of what not to do is, don't stand on the sidelines. Don't be the guy doing nothing, even during times like this. We have watched physicians be nimble as heck the last few months in an effort to care for their patients. And so as everyone is kind of seeming to settle into a new normal, as some of the COVID hysteria and news cycle is becoming a little less inflamed, I would encourage you to keep on doing what you're doing, regardless of what's going to happen, because these types of arrangements, I don't think are going to go away. I know that's pretty high level, so we'll let Joy and Lauren weigh in.
Okay, I'll go. So I was reading an article this morning, and it said don't squander this time, don't squander this crisis, essentially. And it's like a chance to make changes. And if the changes don't quite work the way you expect them to, it's still a chance, as Robin's saying, to be nimble, to readjust, to do some really, really quick PDSA cycles, perhaps, in your practices. With regards to MIPS, I do think, so I don't think CMS can just make the whole program go away for a year. We've been working for 20 years now on this path to value-based care. And the reason I got into it was because I think it matters. I think that MIPS, however, is an imperfect program. We all know that. But I think that the more we can do to work on improving quality, and however that aligns with MIPS, you know, maybe the MIPS measures aren't the best measures in the world, but find some measures that really align with, or sort of align with, where you're going in your journey to you know, better patient care. We have been focusing lately on the cost component, and you know, a lot of very expert people say 20 to 30% of all medical care is from a cost standpoint is wasted. It's not necessary, or it's incorrect. So you know, we're sort of shifting some of our focus to the cost component, because it is becoming a larger part of MIPS, and there is a lot of work we can do there to provide standardized care, to provide a lot more preventive and wellness care, to reduce the cost of care, to reduce the amount of times these patients are going to the doctors for unnecessary things. And I will get off my soapbox. Sorry.
I love your soapbox, Lauren. I'll echo and just really encourage people to be thinking about the long-term quality of care that they want to be providing to their patients, and ultimately find ways, like you said, MIPS is totally imperfect, and all of these programs are an iterative process. I anticipate that every single year they're going to continue to change, but find ways, you know, and components of the program, and category by category, find ways that it aligns with your long-term strategy and your long-term goals. The things that you would likely be wanting to do anyway to improve care, you know, for your patients, or to improve processes within or workflows within your organization, or, as they're always saying, to reduce costs. Like the whole cost being, you know, there's so much waste in terms of cost within the healthcare system. Now would be a great time to start figuring out ways that we can be more either careful or thoughtful, or find the gaps in care, use the data and the tools that we have available to us to find ways to close those gaps and just do better overall. And if at the end of the day you're providing better quality at a lower cost, but it doesn't get associated with a score, oh no, like somebody still wins. I would argue that your patients are still winning. So that would be the ultimate goal.
Right, great. Thank you so much, each of you. I really appreciate your participation on this panel. I wanted to let everybody on here know you will get a copy of this presentation via email, either later today or first thing tomorrow morning, as well as some important links that the three of our panelists would like to share with you to help you move forward. There are some handouts in the bottom right-hand corner of the screen that show a little bit about who Chirpy Bird and Healthmonix are, that we can help you with your MIPS reporting. As well as we have a webinar coming up not next week, but the following week on cost. And moving forward, please pay attention to our webinars as we will keep these going. And we would love to hear from you what you thought. There'll be a survey at the end when we close out. Let us know how it's going. And thank you once again to our 3 awesome panelists. Appreciate it, everybody, and have a great Memorial Day weekend.
Thanks, Mike.
Thank you, Mike.
Thanks.